Okay, we're going to go ahead and get started with Vascular and Heart. Please feel free to snack and drink coffee at your leisure. Earlier today, we talked about how ALGS is highly variable, and most people with ALGS have changes in the jagged 1 and notch 2 genes. But what symptoms result and how severe those symptoms are differs and affects each person. We're going to go over things you guys have already heard 100 times today. We're going to just pound it in, and then you can ask specifics. Of course, it's like the roll of the dice because, you never know what to expect, and that's what we've all gained to learn. It's true even if the same gene mutation is present in several generations of a family. So there's the roll of the dice, another roll of the dice, piece of the puzzle. There you go. Because ALGS differs from one person to the next, it isn't easy to talk about something like vascular and heart concerns without first saying that they're only a piece of the puzzle. And as you know, when you start to dive into one issue that your child might have, it's like the piece of the puzzle, and you got to get to the next train and the next train and the next train until you get to the caboose. Our hope is that this session is to hit on some of the more common challenges with blood vessels in the heart that the ALGS warrior might encounter. If we miss something, please bring it up in the Q&A after. I'm going to say we're just going to go ahead and executive decision Q&A anytime. Just raise your hand. So you got to have a heart, right? Piece of the puzzle. The heart's main job is to pump oxygen-rich blood to the body after it pumps oxygen-poor blood to the lungs. Here's how that works. Do one of you want me to just do it, or do you want to just say it?
I think you should go
Okay.
We don't have to act it out, or?
No. We could, but I want to spare everyone. Oxygen-poor blood from the body comes into the right atrium, one of the upper chambers of the heart. The blood then flows into the right ventricle, a lower chamber, and is pumped to the lungs. Oxygen-rich blood from the lungs comes into the left atrium, an upper chamber. It's all very confusing. The blood then flows into the left ventricle, a lower chamber, which pumps it out of the heart to the rest of the body. The arteries and veins make up the vascular system, and arteries carry blood away from the heart, and veins carry blood back to the heart. Is everyone following? Okay. The cardiovascular system has several important functions, including delivering oxygen, nutrients, hormones, and other substances to the cells and organs in the body, helping the body meet the demands of activity, exercise, stress, and helping maintain body temperature. Heart disease. Most people with ALGS have some kind of heart problems, and most problems happen on the right side of the heart. So for my daughter, she has a very mild pulmonary stenosis. It may never be an issue, we were told. We see the cardiologist once every 5 years. We're one of the mild cases, where some have heart just as their more dominant issue. These changes cause blood to slosh around in the heart in unusual ways, called a heart murmur, and can make it difficult for the blood to move throughout the body. Heart problems also can cause cyanosis or blue baby when the blood does not have enough oxygen in it. I know we talked earlier about blue baby issues with that blood flow. One of the common problems with ALGS is narrowing of the pulmonary arteries, which I'm sure many of you have issues with, or the pulmonary stenosis, which affects blood flow from the right side of the heart to the lungs. But there can be other problems too. VSD, ASD, tetralogy of Fallot, aortic stenosis, coarctation of the aorta. These are all common issues that some of you might be experiencing with your children. Ventricular septal defect, or VSD, is a hole in the wall that separates the bottom two chambers of the heart. Atrial septal defect, or ASD, which is a hole in the wall that separates the top two chambers of the heart. Tetralogy of Fallot, which includes VSD, as well as an obstruction from the heart to the lungs, the aorta being located over the VSD and a thickened muscle in the lower right chamber. Aortic stenosis, where the aortic valve does not fully open or is blocked in some way, decreasing blood flow from the heart. And coarctation of the aorta, which is when the aorta is narrowed. Anything to add so far? Moving right along. What's that?
So sometimes the test is really, really bad, and like the whole pulmonary tree is a threat.
Okay.
Did you remember the part where he said he was going to be quiet? Remember that part?
I want you to feel free to turn the mic on. You better just give it right to him. You know how he likes to butt in. I really like it when you do say stuff because it helps. My daughter doesn't have hardly any heart issues, so I might struggle with this, and I don't know if I'm saying something wrong, and I want you to correct me.
Okay. So can I say one thing?
Yes,
and
absolutely.
And as I said last session, but probably most of you weren't there, I always wanted to be a cardiologist, and then it didn't work out for me. So I do have sort of cardiology envy.
Interestingly, I don't have GI envy.
But we just decided we're going to go on the road together, and we're going to put on a show. So the one thing that is probably clear to people, so Alagil said you needed to have a murmur. And it turns out that the murmur is like the most common constant feature of people who have a gene mutation. But everybody calls it heart disease, and I'm going to go out on a limb and just say for almost everybody, it's pulmonary artery disease, and it's an arterial disease, and Alagil is an arterial gene disease, and most people have a good heart and something above the right heart that's not good. Can I get away with saying that?
Yeah.
All right. Now I'm not going to say anything else.
Shakira.
We are not running the quarter-mile relay together, that's for sure.
I got it. We're good.
I found our third panelist. She's hiding back there. Come on up here. Girl. Come on.
Let's cheer her on.
Woo!
Yeah.
Shakira Combs. Shakira is the mother of two beautiful children, Sean, 12, who has ALGS, and Olivia, who is 8. Born on the beautiful island of Jamaica, Shakira migrated with her family to the U.S. at age 13. She works full-time in the finance department at Hennepin County Medical Center in Minneapolis. Shakira is a Seventh-day Adventist who loves the Lord and enjoys going to church. In her spare time, Shakira loves gardening, making salsa, can I have your recipe? And jam. Her hope is to share, from a mother's perspective, her experience of living with a child who has ALGS. Welcome.
Thank you.
Break up the monotony over here. Okay, so as we're talking about heart, what can we do to fix it? What can we do to fix these things, doctors?
Oh, is that a question or is that
No, I'm moving on. Some of these problems can be fixed with surgery, while others are either left alone or helped with various non-surgical procedures. Tetralogy of Fallot has to be fixed with open heart surgery, and the surgery is usually performed between 3 to 6 months of age. VSD and ASD can be repaired with a patch over the hole between the heart chambers. In coarctation of the aorta, the narrowed piece might be removed in a surgery and the vessels reattached so the blood flows more freely. Narrowing of the arteries, such as in pulmonary stenosis, might be widened with stenting or balloon dilation, but this is decided on a case-by-case basis and is not always needed. Anything to add?
So ballooning is controversial. So sometimes some people believe in ballooning, some people believe in surgery, but at the end of the day, you have to figure out if anything is needed. So
Okay.
before people just go in and use balloons, obviously they need to make sure that something needs to be done.
And there are different types of ballooning, correct?
There are different types of ballooning. There are different types of balloons with or without stenting. We were talking about this before. There's sort of a funny term in the medical world called the oculostenotic reflex. Sorry. I have this. I should probably use it. What I'm hearing from back there.
We are webcasting.
There you go. Sorry. So there's a sort of a funny phrase called the oculostenotic reflex. Oculo referring to your eyes. So if you see a stenosis, you should do something about it. That's not always true. So you should fight that reflex, and you should make sure that your cardiologists fight that reflex unless there's a really good reason to do something.
Okay. So we need oxygen. This here is baby Lizzie. I don't know if some of you remember Lizzie. She was here at our last symposium, 2014. Very special young lady. They came to the symposium, and while they were here, she had to go to the hospital and missed a big portion of the symposium, and she did later pass away, not directly after the symposium, but she is no longer with us today. She had many, many heart problems related to ALGS. Some of the heart problems in ALGS might cause an ALGS warrior to have a lower than normal level of oxygen in the blood, especially in the arteries. This is because the disease can affect the right side of the heart, the arteries from the heart to the lungs, and the blood vessels in the lungs. Oxygen deficiency is called hypoxemia, and it can cause shortness of breath, blue lips, pale skin, headache, confusion, or tiredness and fatigue. A person with ALGS might need oxygen supplementation to bring their blood oxygen to normal levels. Fatigue and tiredness. Backing up. Low oxygen intake also can cause fatigue and tiredness and lack of energy in a person with ALGS. Fatigue and tiredness can be normal and are a way for the body to refresh after physical activity, lack of sleep, emotional stress, but can also be a sign of a more serious issue. It isn't unusual for an ALGS warrior to be tired and need a lot of sleep, although this might be a challenge due to itching, stress, and other factors. And I know most of you probably are up nights with your children, either scratching, feeding, soothing, whatever it might be. Blood vessels and vascular challenges. That was a whirlwind tour through the heart problems, so we just kind of zipped through them and some related challenges that an ALGS warrior might encounter. But this session is also about vascular issues or problems with the body's blood vessels and circulation. People with ALGS might have changes in the blood vessels in the kidney, liver, and brain, as well as the heart. These changes might include aneurysm or dilation, and stenosis or narrowing in other parts of the circulatory system. Here are some of the most common blood vessel problems that you might see in someone with ALGS. Several things. Moyamoya, aneurysm, renal artery stenosis, among others. We've already talked about some of these challenges, but let's look at a couple more in detail. So we have Moyamoya. I would like to read what this says about Moyamoya, and then one of you chime in. Most common change in blood vessels in the brain is narrowing of the internal carotid arteries. Some people with ALGS who have this symptom have been diagnosed with Moyamoya disease because it appears similar to the narrowing seen in ALGS. In Moyamoya, there is a narrowing or blockage of the internal carotid artery at its end, and beyond that, extra growth of vessels to compensate. Moyamoya is a progressive disease that worsens over time and causes strokes and seizures as the vessels continue to thicken and narrow. In some cases, it might be necessary to correct the vessel narrowing with surgery.
That's your cue.
That was like perfect.
Coffee break?
Yeah, coffee break. No, I mean, this is a big concern, and it's something that is silent for a long time, and once it becomes symptomatic, it becomes hard to deal with. And we talked about, yesterday and again in one of the sessions this morning, what are the things that are clearly part of Alagille syndrome but progress over time. And so this is one that's not consequent to nutritional problems or growth or other things. And so we have seen patients who have Moyamoya and they don't think they have anything else at all, and it's due to JAG1 mutations. And then certainly the neurosurgeons see this in some other genetic diseases and in other things that are not clearly genetic. And I think the important thing about this, so the brain really only gets a very limited, huge amount of blood supply that comes up to it from the heart. And if that is compromised in any way, the brain is jeopardized and eventually really has, strokes and other problems. There is a surgery for this, which is unusual and extremely successful, but it has to be done at a time before damage starts to occur. And I mean, more or less, there's an artery so an artery is high blood flow, high oxygen blood flow coming out of the heart. There's an artery that comes up along the outside of the skull that you can feel your pulse sometimes, and people talk about pounding headaches right here sometimes and things. And the neurosurgeons can take that artery, drill through the skull, plug that artery onto the outer surface of the brain. They don't have to plug it into an inner vessel. And this blood vessel grows branches that then perfuse the brain. So it's an incredible operation. It's called synangiosis, but it takes a long time for this to happen. And so that's one of the reasons why we say that people need to have a vascular study of the brain and neck at intervals, because if you are developing this, or if you're in the early phase, we talked about headaches, seems like only 2 sessions ago. If you have this and you find it early, you can do a great job revascularizing the brain. And if you wait too long, you'll have stroke or death. So it's an important thing to think about. It's not one of the things that was really recognized by Alagille or for the next 10 years or the next 10 years after that. But now we recognize that this is clearly an important part of things. And like most of the vascular things that we're going to talk about here, it's on the artery side and it's too narrow. And so the aorta too narrow, the pulmonary artery too narrow, the renal artery too narrow, and the brain arteries too narrow.
When do you do your first imaging?
So, that's a great controversy because, of course, we're liver doctors and we have no real business telling the neuro people what to do. And we did try, and we tried, with this group and put together what I thought was a great NIH grant, and the NIH didn't think it was a great NIH grant. They actually thought it was astronomically too expensive to have them pay for everybody to get MR angiography. We start between 5 and 10 years of age. And what we try to do, so it's a special kind of MR where you're looking for blood vessel. So it's a little bit different kind of sequence than if you're looking for tumor or something else. But, an MR, it's not radiation. It's quite expensive, but so are a lot of things that, happen in the life of Alagille. And the one thing about it is it's kind of a slow test time-wise, and it's in a big tube, and it's super clunky, and it makes people claustrophobic. And so some of the little kids don't love it. And we don't love like the open MRI. It doesn't give us as good kind of a picture. So we do MRIs in little kids under general anesthesia. We don't love to do this screening test under general anesthesia. So we usually wait until the kids are a little bit older, and then we hit them with a sedative, but not with anesthesia. And that usually works quite well. Plus our child life people tell them this is the coolest thing they'll ever do and stuff like that. And it makes it fun, and they get great stereo headphones, and they can listen to, whatever. But you are in a big, loud magnet for, at least 45 minutes that is going clunk, boom, and the air is blowing through. And for people are shaking their heads, so they've had it on more than like just their knees. You really have to like breathe slowly and say, you know what, 100,000 people have lived through this test, and I'm going to live through it too. But so we don't. The little kids, if they have something that looks like a stroke, or if they've had a head injury, a CT scan, a CAT scan, is like, bzzz, and you go right through these new machines, and you're like done. It's really, really quick. But it's a lot of radiation, and it's different sort of things and different dye. So this is a great way to get a good image. But so we're mostly in the 5 to 10 year group. But if you said to us, show us the data, we can't really show you like the data that says that this is cost effective. What we can show is, look, we found this here, we found this here, we didn't know about this here, and this really mattered here. And we would definitely get one, it's your baseline, and then get another one 5 to 7 years later, and then we have found, children who have had a stroke, nobody knew. But if you have something happen, you're out on that soccer field, and you whack your head, and they bring you in, and they run you through the CAT scan, and you look like you have a stroke, everybody goes nuts appropriately, except for the fact that you look and go, you know, it looks exactly like it did 4 years ago before she started playing soccer. So that's a great important comparison. You have a baseline, you know. So it serves as a baseline and an early warning indicator. And sometimes you find things that you didn't really want to find, but they're really important, and it's better that you found them.
So yesterday you and I had a discussion here for a few minutes regarding my doctor didn't believe that it was something that needed to be done, because if we did find something that we didn't want to see, what would we do about it anyway? And you and I talked about that. And I don't know if any of you get that pushback from your doctors on whether it's the right thing to do, but I recall getting that feedback from my doctor for many years, and I actually wrote the board members an email and asked, what's your opinion and what are you told? How can you address that to be a better advocate for the doctor without being a pushy parent, but hoping that they will understand the importance of a baseline MR?
And of course, your doctor changed his mind later on, right?
It took 11 years, but by golly, he did.
Yeah, well. You know, I think one of the things that you can do is, you know, so this is very clearly in the literature now. The problem is you're dealing with a liver doctor and you want a neuro study. And that's, you know, we actually had to code it a special way because we can never remember exactly the way our neurologists want this test to be done, which is only on this machine, only this way, yada, yada. But there are 3 really good papers that detail these kinds of problems. And you know, now with PubMed and Google, you can just search them and print them up. And, you know, you can say, you know, I was at the annual symposium. They said this is important to do. And here are these papers. I know you probably have them, but I brought them in for you anyway. And, you know, we really need a baseline, you know, study and make sure there are no problems. And I think most of them will. You know, so this is not a dangerous test. You know, if you said to your hepatologist, where they know what they're doing as opposed to in the neuro area, you know, my kid's 10 now and I want to get a liver biopsy to just see how much bile duct paucity is, they'd say, you're crazy. It's a risky test. It's an expensive test. It's a risky test. And we're just not doing it. We're not talking about it. But a head MR is not a risky test. It's expensive, but there are clearly indications in literature for it. So
thank you.
Somebody will still tell you no, but, you know, we feel kind of strongly about it.
Thank you.
Is anybody on this panel on any of those landmark papers?
No, probably.
So, for those of
So
you,
if somebody were to Google search it.
For those of you who are looking for it, Circulation is the journal, 2004, right?
Yeah, there's a couple, yeah.
His truly. And the first author was Kamat?
Kamat is one, Emmerich is another.
And him.
Yeah. So.
Thank you. Let's talk about bleeding. Bleeding inside the skull or intracranial bleeding can happen in a person with ALGS. Most of the time, the bleeding occurs spontaneously without any head trauma or there being any kind of clotting disorder. It's impossible to predict if someone with ALGS might have a bleed, but precautions can be taken to reduce the risk, such as wearing a helmet during physical activity like soccer. It's important to investigate any head injury immediately.
Yes.
Things to look for. Some of the things to watch out for that might indicate that a stroke or bleed has occurred include headache after a head injury, sudden weakness of arms or legs, slurred speech, numbness, and seizures, like my slurred speech up here. In some cases, there will be no signs that bleeding or a stroke has occurred, and it will only be visible in an MRA, like he's saying, or other type of scan of the brain. Any of the above symptoms should be investigated immediately by a specialist. Can you touch on those symptoms a little?
Yeah, I think you know, the thing that we say to families is when you have a head injury, you know, the kids whack their head from time to time. And I think as parents, probably we all have had one time where like they just went backwards or they went forwards. You know, I think that if you feel like it's a hard knock, and many of the bleeds are with a head injury, but it's a surprisingly minor head injury for the level of the bleeding. And we now know that that's probably due to a whole bunch of different adverse factors in Alagille syndrome. But I think if you have lots of consciousness, you absolutely are going to the emergency room. And when you're in the emergency room, you just tell them, look, this is a disease that bleeds into the brain, and I have been told that we have to get a CAT scan right now. And there is no chance they're going to refuse you in that kind of scenario. And, the emergency room CAT scan is almost like the same word now. You go in with belly pain, you get a CAT scan. You have a headache, you get a CAT scan. I mean, they're really quick about those things. But certainly with a head injury, you would want to do that. You want to observe more carefully. You might want to observe overnight in the hospital, depending on what it looks like. Sometimes you get these tremendous, welts that are sort of bleeding under the surface of the bone that can really look like they totally change the shape of the head. And yeah, sure, if you see that there's a facial asymmetry or a pupil asymmetry, or they really seem out of it, they're not quite rousable, they keep vomiting. I mean, those are all urgent signs where, maybe you don't go to your big academic center, maybe you go to the place that's, only half an hour away and have them call and say, this is what's going on. And, if you catch a bleed early, just like in old people, if you catch a stroke early, but these are different kinds of strokes. But if you catch it early, you can prevent a lot of damage and really look brilliant. And if you sit on it for a while, the damage may or may not ever be recoverable by, physical therapy and all those other sort of things that take months or years to do. So I think it's really, your pediatrician needs to know this. And, they won't remember maybe, but when you call, you say, and remember, this is a process where this is a really, 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 really big deal, and here's why. And then they'll move into, high level, and it wouldn't be different from, someone who is highly anticoagulated for a different disease or something like that. I mean, they know what to do if they know the process.
Thank you.
I just had a quick question. It's my daughter at 9 months had a brain bleed, and does she have a higher rate of having another one, or does she have the same chance as somebody else that hasn't had a brain bleed before?
Yeah, so that's a great question. And right in the middle of the bleed, it will be impossible for them to know the answer to that question. So was there a reason for the bleed that you knew, or it was spontaneous?
Spontaneous.
Yeah.
Well, she was at the point of, she was standing on things, and she could have bumped her head, but I didn't notice anything.
But there wasn't anything noticeable, and there was no bruise on the skull.
No bruise, no.
Yeah. So that would be the kind of thing where obviously, did she require to have the bleed evacuated?
No, She ended up having a seizure, and she was just evaluated and watched for 7 days.
Yeah, so she came in with seizure without fever, and they looked at her, and something made them do a CAT scan, and they saw that there was blood in the brain.
Yeah.
And they watched it. Yeah. So that for us, how old is she now?
She's 4.5.
Yeah. So, there will be some changes from that bleed that would show up on a scan at this point. Not blood, but there, might be other changes in, brain sort of density or other things. But I think we would say very definitely we would, at this point in time, get an MRA, an MRI arteriogram to look and see what is there. And you might find nothing, and that would be great. Or you might find the cause of the bleed, which now you decide whether or not you should take care of. So we would follow that up for sure.
Okay. Thank you.
Any other questions on that? Oh, my aching head. So there are other causes of a headache or migraine than bleeding or a head injury. Any pain or discomfort in the head, scalp, or neck is called a headache, of course, while migraine usually occurs with other symptoms such as vision changes, sensitivity to sound, light, or nausea. Some people with ALGS have reported recurrent or frequent headaches or migraines. It's hard to know whether headache or migraine is related to Alagille syndrome or some other cause, but if a person has one for a prolonged amount of time, they probably should see a doctor or other health professional. What constitutes a prolonged period of time?
And in a little kid,
Mm-hmm.
and I think if you have a couple of headaches a week repeatedly, or a headache that lasts 6, 8, 10 hours, something that comes out of the clear blue. Some of these are really terrible. Right? There's a lot of overlap between normal, sinus, migraine, and catastrophe. And so as a parent, it's not really your responsibility to know the difference between those things. So I think when you see one of those kind of patterns, somebody asked me, my kid has, a headache 30 minutes once a week. Is that what you're talking about? The answer is no. I mean, that's, and there are people with migraines who have headaches that last 3 days or 3 months. And those are migraines. And migraine itself is not really a part of Alagille syndrome. Migraine is like commonly genetic in families, and it's migraine, and you could certainly have both. But you also could have a structural problem, and so I think, engaging your neurologist, earlier than you might otherwise for your other kids, if something's going on, is wise. And the scans they're just great these days. They're better than a physical exam, and they really tell you a lot of things, and they're not risky. So.
Okay. Baseline MRA or not? That's the question. It might be helpful in managing Alagille syndrome to have an MRA of the brain to see if there are any changes that need to be monitored, but the value of this procedure is really unclear. But not really. We believe we should do it.
We say yes, they say no.
Yeah.
We say why, they say I don't know.
Potato, potato. Some people with ALGS with normal MRAs have gone on to have intracranial bleeds, while others with normal MRAs have developed other symptoms or changes in the vessels in their brain, such as aneurysms that show up on subsequent scans. They may or may not show signs of stroke or bleeding. The current recommendation for the ALGS warriors to have a baseline MRA, as long as the procedure can, it is the current recommendation to do that, as long as the procedure can be done without any kind of sedation. Visible vascular changes. There are some vascular changes that are visible because they occur in the skin or shallowly below the skin surface. Two that can occur with ALGS liver disease are spider angioma and varices. Spider angioma is a collection of blood vessels near the surface of the skin that often contains a central red spot and reddish extensions that radiate outward like a spider's web. Varices are caused by dilation or engorgement of veins throughout the body when a person's liver is damaged and blood builds up in the portal vein, which is portal hypertension. Sometimes these are visible close to the surface of the skin, particularly on the abdomen. Someone with ALGS might have prominent veins at the temples or across the bridge of the nose. It's unclear whether these are related to ALGS. Anything to add?
So I think maybe this is clear, but now we're going to do a tag team on one word that I think everybody should have very clear in their head, which is hypertension. So, to a gastroenterologist, I'm going to tell you about my kind of hypertension, and then you'll hear about the real kinds of hypertensions. So, to a liver doctor, a hepatologist, we spend all of our time thinking about portal hypertension. And so that's a venous side hypertension. And what we as physicians get hypertensive about as a pressure is like such a low normal heart pressure that they wouldn't even blink. So on the venous side, so veins are thin-walled, and a portal system, and there are really only, I think, maybe 2 of these in the body, where an artery goes out to somewhere from the heart, and it feeds something, and then the veins coming back from that don't go straight into veins in the heart, they go somewhere else. And so in the abdominal cavity, there are 3 arterial beds that go out and do all the stuff between here and here, and then they come back, and they come back from the spleen, and they come back from the upper gut and the lower gut, and then they all go into this little thing called a portal vein, and they go into the liver. And so they should be normally running back to the heart, but then they go to another organ. And that's the beauty and the magic of the liver, because then once they get into the liver, they get dispersed out in this incredibly complicated, ordered, organized sort of way where, you know, as Dr. Quiroz said, the liver is a filter. The blood basically can't help but touch important cells going all the way through the liver, and it's very cool. But it's artery to organ bed to vein to organ bed, and then back to the inferior vena cava and the heart. So when that system gets a little bit backed up by pressure, and those pressures on the venous side are really low compared to arterial hypertension, then veins swell. And so arteries like do other stuff when they're under high pressure, but veins swell and they stretch because the walls are not very thick, there's not a lot of muscle around them, and they swell around the rectum and you get hemorrhoids, and they swell in the esophagus and you get varices, and those varices are very thin-walled. When you look in with a scope, they're stretched water balloons, and they're under a ton of pressure for a vein, and they can rupture. And when they rupture, they can rupture and you can lose 1/3 of your blood volume in an hour or 2. And we said this morning, red blood in the stomach, acid treats it, it turns black. And if you defecate, so sometimes they vomit and they just vomit copious amounts of red. But if it's a sort of less massive bleed, you get this very black tar-like stool, and it really smells otherworldly. I mean, like in a hospital or, you know, in an emergency room, you can smell it like 4 rooms away. But so that is portal venous hypertension, and it's very important in liver disease and cirrhosis. But the thing about Alagille syndrome is they have all different kinds of hypertension, and they're all kind of like, they're all markedly increased in Alagille syndrome, and they're all very different in what they are. So I'm going to pass over the right and left heart to my right and left heart expert.
So the 2 other types of hypertension, if I'm listening correctly, one is called systemic hypertension, and that's the one I think most people are familiar with just in general. You go to the doctor's office, they put a blood pressure cuff on your arm, and they say your numbers are too high. Right? So a normal blood pressure, for example, for grown-ups, let's just say in a perfect world, is 110. The top number is 110. Bottom number maybe 60 or 70. Now the numbers are creeping down as to what's important. 120 as the top number may start to be important, but there are patients who can have much, much higher blood pressures. The top number could be 140. In adults, it could be 160, 180, or 200. And in a similar fashion in kids, their blood pressures are normally much lower. The top number could be 80 or 90 or 100, and they could creep up to 120, 140, 150. In those particular cases, not only does it cause the heart to work a lot harder, but the big issue there is that those same blood pressures are seen by the blood vessels in the head, right? And when the blood vessels in the head are abnormal to begin with, and frail or friable to begin with, the risk of bleeding or stroke is much higher there as well. So the kids with Alagille are at risk for the same types of things we were talking about before with the stroke or the bleeds as a result of having high blood pressure as well. Okay? The third type of hypertension, if I'm reading you correctly, is actually hypertension as it relates to the narrowings or the stenoses in the lungs. Some people will talk about this as pulmonary hypertension. Technically, it's just really hypertension of the right ventricle, which is the chamber, bless you, the chamber that pumps to the lungs. So if you have all of these narrowings in the pulmonary vasculature, in the pulmonary bed, almost by definition and by obligation, the pressure in the right ventricle necessary to push the blood past those obstructions has to be higher. So then you end up with something called right ventricular hypertension. Some people may term that pulmonary hypertension. It's not exactly the right phrase, but it's right ventricular hypertension. The concern with right ventricular hypertension is over time, the right ventricle can fail. And that doesn't mean it stops working, it simply means it doesn't work very well. Okay? And so you end up with RV dysfunction, right ventricular dysfunction. Those are the other two?
Beautiful.
There you go.
So you have three kinds of hypertension to worry about. So here's the toss-up question. Big spleen is correlated with this or this or this. Systemic hypertension, raise your hand. Right ventricular hypertension, raise your hand. Yeah. Portal hypertension. All right. So now the trick question. If you have right ventricular or biventricular failure, and you get backup pressure on the liver, and that backup pressure goes to the portal vein, which then goes to the spleen, and of course you're in trouble, can that make a big spleen? Everybody who thinks yes, raise their hand. All right, everybody passes. Time for a coffee break. All right, good. So I think it's complicated because depending on which doctor you go to, you hear about, so you can get blood pressure cuff, systemic hypertension from a kidney artery stenosis, which we're seeing more and more is something that occurs in Alagille syndrome. You can get chronic headaches from high blood pressure in Alagille syndrome from something that's going on with your kidney artery, which is not exactly the same as the kidney disease that, you know, we also see. And these things all, they have consequences commonly in other organs. So, but now we've passed all the hypertension, higher pressure, vascular sort of things. The spiders. So I've seen a couple kids here who have little red freckles. And those little red freckles are the spiders. And if you put your finger on them, or if you put a glass slide on them, and they're very commonly cheeks, cheekbone, upper chest, they turn the same color as skin because there's not anything that's really red there. It's the blood flowing through this dilated structure. And they do commonly have a little central piece that you can feel and then blood vessels that come out. They don't mean any, they go with chronic liver diseases. They don't mean anything bad, except if you pick at them, they really have a tendency to bleed for a while, and then you still get the piece back that is the sticky uppy piece.
For those of you who don't normally walk around with a glass slide, you can use your glasses.
Yes.
Works the same way.
Yeah. And your glasses are all smeared when it's over. But that's a very good tip. And to tell you the truth, next time in the clinic, when I see one of these and I want to make my demonstration, I'm not going to go run into the back room for a glass slide. I'm going to take off my quadruple focals of old age, and actually one of them will probably magnify it, and one will. Next slide. Next slide, please.
Moving on. Encephalopathy or foggy brain. I know we touched on this in several different things, so we're just gonna, pound it in. One other challenge that is related to vascular and heart issues, because it involves circulation and brain function, is encephalopathy or foggy brain. This happens. Well, I'm not gonna catch up here. Hold, please. There we go. It can cause forgetfulness, poor concentration, hand tremors, disorientation, slurred speech, and sluggish movements. Oftentimes, our allogeneic kids waiting for transplant have encephalopathy to some degree. There are medications that can be used to treat this, but sometimes the only real solution is a liver transplant if the liver is too damaged.
Yeah, okay. So I really don't like the term foggy brain. And encephalopathy means something specific to us, which most people never have. So the question really is kind of an altered mental status or altered alertness, and that's really where a lot of these things sit. So Dr. Quiros almost said, and then he didn't say, at the end stage of liver failure, people get hepatic encephalopathy. And that's due to a number of the toxins that we said the liver, takes care of, and it can't get rid of them. And so sometimes we measure an ammonia. There are some kinds of liver failure where on Saturday you have no disease at all, and by Wednesday you're in a coma. And that is never Alagille syndrome. Encephalopathy from liver, if you truly have encephalopathy, that is always urgent call to transplant, no matter what the cause is, because that can lead to increased risk of death from transplant, permanent brain damage, other things, So that's this thing on the end of the spectrum that really is liver, but we've talked with in a couple different places. Alagille syndrome is mostly a defect in excretion and absorption, and mostly synthesis, which is a different function, is okay, and mostly detoxification is okay, and only a small percentage of Alagille patients go on to have cirrhosis or liver failure. They have a failure of one of the functions, but not of all of the functions. So encephalopathy is really not common from Alagille syndrome. On the other hand, altered mental status, and I'm going to throw this back, but so this I think is the first symposium where we've not had one or two kids on oxygen who were totally blue. And, to me, I'm sort of amazed with the operations that are life-saving for tetralogy and really severe tetralogy, where these kids are doing really well, but their oxygen saturations are the kind of thing that if they happened in my endoscopy lab, we would call a code. And they walk around with these numbers all the time. So in that kind of scenario, I'm going to pass the mic, but with an arterial oxygen saturation of, 60%, and the cardiologists go, no, they're really good. And I look at these numbers, and I'm like, it's like a college math class where you get like a 68, and then you get the curve back, and you got an A, but it's like, so for a cardiac surgeon, sometimes those kind of percentages are like great, and the kids live and do well. But what really happens when you have that kind of level of arterial saturation?
So 65 may be a bit extreme. We don't see 65 a lot, fortunately, but it's not unusual for us to see the 70s, and it's definitely not unusual for us to see the 80s. And we have tons of kids with all different versions of heart disease that live in the 70s or 80s sort of all the time. And part of it is how you get there and when you get there, right? So if you're chronically in the 70s or 80s, that's what your body is used to. If you start in the 90s and you abruptly go to the 70s, then your body will not like that, and you will get, in fact, many of these similar symptoms and many of these similar sort of feelings. But for the kids who have the forms of heart disease that weren't able to be repaired for one reason or another, there are mechanisms, coping mechanisms. For example, you get more red blood cells. You become what's known as polycythemic to carry the extra oxygen, even though the saturations are much, much lower. But from a symptom perspective, you will get many of the symptoms that you would expect. You'd be a lot more fatigued, right? You wouldn't have the energy to do many of the things that other kids can do, and you certainly would tire out when you're doing even some of the simple things before the other kids will, right? And so that's all related to being able to deliver enough oxygen for the body to do what it needs to do.
Thank you. So we want to wrap up this session. I just want to put it out here for questions, but I also want to put you on the spot for a second. She's up here for a reason on this panel. Can you explain to us why? What is your link to vascular panel here?
My son was recently diagnosed with an aneurysm, and it's about 3 millimeters. Well, it was 3 millimeters on the MRI, but then he had a CT angiogram done, and then it was measured at 2 millimeters. So, yeah. So I think the question now is, do they treat it or do they watch it? And I did bring records and imaging to find out, you know, if it's something that should be treated or watched. Because the neurosurgeon, it's kind of up in the air. He really doesn't know what to do. I mean, he said he can watch it, but, you know, he's 12, and so it has a chance of growing. So that's a concern.
Did you have a baseline MRA?
It was just a routine MRI that was done. We weren't told why, you know, he was having the MRI done, and I didn't even know he had the aneurysm. I thought everything was normal until I think it was like a week later the doctor called and said, you know, he has an aneurysm. So, yeah.
So, is there a standard percentage of how many children with Alagille have aneurysms as opposed to not?
So that was what we had wanted to try to study and figure out by doing like 100 kids and seeing. So the numbers that we know are sort of heavily weighted by the fact that we did these kinds of studies on people who had problems. And so, you know, when the person has a problem first and then you do a study, the percentage of those studies that show problems is, you know, biased in a high direction. I think we don't know. What we do know in some studies is that, you know, the cause of death in some studies, and again, looking at people who are probably more severely affected are the people who end up at academic centers, the people who end up getting reported. But it's been one of the major causes of mortality, you know, the bleeding into the brain, stroke, you know, Moyamoya, et cetera. Not that it's more than like 14%, but still that's a pretty significant number, you know, for something that otherwise you would think is a, you know, a liver disease, what we think of it. But the only thing really that predicts mortality that you can see in the first 2 or 3 years of age is all cardiac. So if you have a hole in the heart, so not so much pulmonary artery, but anything else on that list, those children have a significantly lower chance of living to be 6 years of age. And the liver stuff doesn't really change that level of mortality at all, because when you do, you know, if the liver gives out and you do a transplant used to be 80% good, now it's 90% good, you know, so really the amount of total mortality that comes out of the liver is not really that high, but vascular and cardiac, and it really was in the younger kids mostly cardiac. They have an amazing ability to fix some of these hearts and do some really incredible things. So it's much better than it was, and a lot of the papers that you look at include people from 20 years ago. You know, people's memories here even say, you know, 20 years ago, 25 years ago, we did this, but what can be done now is so much different than what could be done 20 and certainly 40 years ago. And, you know, the things that Alagille reported, you know, some of them really go back to the 60s,
Okay,
1960s. Yeah.
Thank you. So we're going to go ahead and wrap it up. We want to let you know that you can absolutely stop him in the hall and get a dance with him. Get a dance with him. Yeah.
I was getting a hook.
So
I thought somebody like passed out there, but it was just.
hurry up, let's go. Thank you very much.